This is Matt Campbell coming from MD Anderson Cancer Center. Would really like to thank the organizing committee with the Kidney Cancer Association for picking my abstract for presentation. Today we'll be discussing a pilot study that we performed with Tremelimumab, which is an anti-CTLA-4 antibody with or without cryoablation in patients with metastatic renal cell carcinoma. And today we're going to be focusing on a post hoc analysis of patients with clear cell versus non-clear cell or variant histologies. These are my disclosures. So the rationale for the study is cryoablation has been found to be immunogenic. And when you do cryoablation with extreme temperatures, it can result in both necrotic and apoptotic cell death, which are two different ways that can stimulate the immune system. In a study that was done in the lab of Dr. Jim Allison, he used a TRAMP-C2 prostate cancer model and found that when cryoablation was used alongside CTLA-4 therapy, animals were more protected against tumor rechallenge as compared to receiving no treatment or either treatment by itself. So this was the study design. This was originally started in 2013, and this was designed by Dr. Surendra Mateen and Dr. Pam Sharma, and I joined this project during the early part of my fellowship. So what you can see here is that we have two arms. So arm A, patients have biopsy collected. They then undergo 2 doses of tremelimumab, and then they have a repeat biopsy or surgery. Arm B is tissue is obtained at baseline. Patients receive cryoablation to a metastatic lesion, and within 1 week started on tremelimumab. They received again 2 doses, and then either had a biopsy or they had a surgery conducted at that time to collect tissue. Patients afterwards, unless they had progressive disease or had substantial toxicity, were able to continue with tremelimumab as maintenance. These were the patient characteristics. You can see that there were 29 patients treated. I'll show the consort diagram with the next slide. But what you can see is that there were 14 patients in tremelimumab only and 15 patients in tremelimumab plus cryoablation. As per most studies with renal cell cancer, you can see it's predominantly male, it's predominantly Caucasian. The majority of patients had a performance status with an ECOG 0 or 1. 60% had no prior nephrectomy, and 40% had a prior nephrectomy, so somewhat sicker than the average patient population. The IMDC or the Hing score, the majority of patients were intermediate risk. So on the consort diagram, what you can see is in the tremelimumab only arm, 9 patients had clear cell disease, 3 had papillary, 1 had sarcomatoid where we could not detect an underlying histology, and 1 had unclassified. In the cryo plus tremelimumab or arm B, 9 patients had clear cell and 5 patients had unclassified disease. These are the progression-free and overall survival Kaplan-Meier curve. And what you can see is that the progression-free survival numerically was improved in patients with clear cell. And you can see where at the tail of the curve, there are still several patients that have not had progression of disease on this arm with clear cell. What you can see with overall survival is that the median overall survival was improved for patients with clear cell as compared to non-clear cell disease. These are the swimmer's plots. On the swimmer's plot on the far left, you can see which arm patients were on, tremelimumab alone or cryo plus tremi, and the arrows are showing ongoing response in 3 patients. The middle swimmer's plot is looking at clear cell versus non-clear cell, and you can again see the top 7 patients with the longest progression-free survival were all clear cell, and that piqued our interest in looking further at what distinguished these 2 groups. Swimmer's plot on the far right is showing the subtypes of different non-clear cell histologies that were included on the study. So this is showing a patient who's had a tremendous durable treatment-free interval. This is a patient who presented with both lung and a left adrenal metastasis. She was good risk. She had received two previous treatments, one with pazopanib, one with nivolumab. She received tremelimumab alone. She was on study for 3 months and then had to come off due to autoimmune hepatitis. And she has now been on surveillance for over 28 months. You can see below, this is the immunohistochemistry showing her baseline immune infiltration and then immune infiltration that occurred on therapy. So you can see a massive infiltration of CD3, CD8 cells. These cells were producing granzyme B and had a higher expression of PD-1. This was a post-treatment change in her lung metastasis. So compared to patients with non-clear cell, patients with clear cell, their baseline tumor tissues have a very distinct tumor microenvironment. And so this is gene expression, which was done with RNA nanostring. And what you can see on the far left is that there's more of a expression profile for Th1 cells in clear cell versus non-clear cell at baseline. When you look at the volcano plot, you can see significant upregulation of genes in both angiogenesis as well as immune signaling. And then when you look at the far right, you see the signaling pathways that are most activated in clear cell versus non-clear cell. You can see, as anticipated, angiogenic pathways that are upregulated, but also interferon gamma signaling. Whereas in non-clear cell, you see extracellular matrix as well as neutrophil degranulation as the top signaling pathways. Post-treatment tumor tissues with clear cell renal cell carcinoma show a significant increase in immune cell infiltration. I'll walk you through several different studies that were performed. So what you can see is that we have patients with CC, which is clear cell, and non-CC, which is non-clear cell. We have pre and then we have post. And so the red is here is pre and then post for clear cell. Blue here is pre and post for non-clear cell. So the first one is nanostring gene expression, and you can see that there's a significant change in terms of T cells post-treatment in clear cell, but not witnessed in non-clear cell. This includes CD8 T cells, an exhausted CD8 T cell phenotype, as well as cytotoxic T cells. For immunohistochemistry, we also found the same changes with increase in CD3, CD8, CD20, PD-1, and granzyme B. We also explored with CyTOF, and with CyTOF, we did see significant changes with immune cell subsets, including CD3 and PD-1 expression. We were interested to look at tertiary lymphoid structures, as this has become an area of significant interest in the field. And what was interesting was we actually detected the development of a tertiary lymphoid structure signature post-treatment. And so we saw this in patients with clear cell, but did not detect this in non-clear cell. And this is an IHC representation of our findings, where we saw these development of these tertiary lymphoid structures. When we explored the role of what cryoablation was adding, we did not detect a major difference between arms. But when we began to look at the clear cell group within this arm, we began to detect some differences. These are small numbers of patients. But what we see down here is pre-treatment, post-A, which is tremelimumab only, post-B, which is cryo and tremi. And here we see a significant change in immunohistochemistry for CD3 T cells, CD8 T cells, CD20, and or a trend towards CD20, and also of interest PD-1, a trend toward increased PD-1 expression in post-treatment tissue. And when we looked at whether this was happening in the tumor or in the stroma, we could detect it occurring in both in terms of CD3 in the tremi cryo arm, CD8 again, the cremi trio arm, CD20, and then PD-1. So in conclusion, single-agent tremelimumab resulted in durable disease control in a subset of clear cell renal cell cancer, but not in non-clear cell or variant histology disease. Interestingly, the baseline tumor microenvironment appears to more favorably predispose clear cell renal cell carcinoma to benefit from single-agent anti-CTLA-4 therapy, and post-treatment changes in the immune microenvironment can be detected with significant increases in immune cell infiltration, as detected by gene expression, immunohistochemistry, and cytoph. Further exploration of combining ablation with immune checkpoint therapy should likely focus on clear cell histology. So these are my acknowledgments. I'd like to acknowledge the patients and families, acknowledge the Conquer Cancer Foundation for their support with my Young Investigator Award. I'd like to thank AstraZeneca and MedImmune for their sponsorship of this study, and all of my mentors that helped me with this project, including Dr. Pam Sharma, Dr. Srena Mateen, Dr. Jim Allison, and all of my partners in different fields, including interventional radiology, without whom support this study would not have been possible. Thank you very much.